Hello, I'm David Scadden. I'm from the MGH Center for Regenerative Medicine. I'm going to talk to you about our efforts to regenerate T-cell immunity. Declining T-cell immunity is something we all face with advancing age. The overall T-cell numbers in our blood do not decrease, but what does change is the relative repertoire of the cells that make up the T-cell pool. That is, the T-cell receptor diversity declines with age. It does this in all of us and will happen chronically with age, but also can happen acutely in the setting of injury from chemotherapy or radiation, in particular in settings like stem cell transplant. Now, this problem is one that results in multiple different problems. In particular, in the setting of transplant, it's associated with infections and graft versus host disease, problems that can be lethal in their consequence. In older individuals, it's associated with increased infections, very poor response to vaccines, a resurgence of autoimmune disorders, and a poor response to cancer. There is currently no therapy for this. It is a natural process that occurs by virtue of the fact that the places where our T cells are made gradually atrophy with age. That is, that T cells are made in two different places. One is the bone marrow, where the stem cells are essentially instructed to become cells that are competent to become T cells. As they achieve that so-called T-competent common lymphoid state, they then emigrate from the bone marrow into the thymus. When they do that, the thymus then educates them, selects them, and really you acquire in the thymus all of the refined responsiveness to particular challenges that we think of when we think of the adaptive immune system. Now, both of these tissues are pre-programmed essentially to decline with age. We know the thymus begins atrophying at the onset of puberty. We know the bone marrow gradually declines, and largely because of the change in bones, with osteoporosis being a common problem of age. So we have tried to take two different approaches based on these two complementary areas that are necessary for the body to make more T cells. So the first of these is work that we did in conjunction with Dave Mooney, who is a bioengineer at the Wyss Institute and Harvard School of Engineering and Applied Sciences. In this case, what we tried to do is to create a mini bone marrow that could be readily transferred into an individual in need. This cryogel is extremely elastic. It is capable of being compressed down so that it can be drawn up into a syringe. When it's injected into, here you see it in liquid, but can also be injected under the skin, it reacquires its shape and it begins to then recruit cells into it. The other is another proprietary technology, which is basically to have a CCL19 expressing subpopulation of mesenchymal cells that are also capable of improving T cell reconstitution, but by a very different mechanism, in this case, by enhancing the function of the thymus. So to the cryogel, what this is basically a technology that Dave Mooney has spent decades enhancing, which is to basically take a molecule that would be, in this case, a growth factor that encourages the education of the hematopoietic stem cell. This is the Notch ligand called DLL4, and then conjugating it to alginate, which then can be formed into a cryogel that is in water in the presence of freezing, which allows one to get a fairly uniform macroporous so-called cryogel that has very sponge-like characteristics. And in that sponge is embedded the hormone BMP2, which helps recruit local cells into the sponge and helps educate them to become bone cells and then invests this local sponge with what is a mini bone marrow that is particularly able to make T cells, as evident from the setting of acute transplant, where we can see that in the setting of a dual BMC, referring to both the DLL4 and BMP2 being present, has an impact on the production of T cells that's dramatically better than either the BMP2 alone cryogel, the empty cryogel, or by the transplant itself. And importantly, what happens is that in addition to the T cell number going up, the complexity of the T cell receptor repertoire increases. So this is a 3D rendering of what are the different component parts of the T cell repertoire. And on the left is something under control conditions, an untransplanted animal. Transplant alone is next, and then just having the BMP2 in the cryogel, followed by what happens if you have the dual BMC, the dual cryogel, in which case you essentially recover what is a full complexity of T cells and seemingly also of comparable numbers. Importantly, what you also acquire is the ability now to respond to new antigens through vaccines and the ability of the animal to also have better tolerability in the setting of transplant. And so this, we think, can be an important adjunct to stem cell transplantation and to improve the ability to make new T cells that go to the thymus. Now, what's going on in the thymus is that there are cells that represent a so-called niche population. We've identified that there's a subset of these cells that are particular niche cells within the stroma of the thymus. These had not been previously defined. We found them in both the mouse and the human, and that these have a particular abundance of CCL19, which one can then take and either use the cells themselves from the thymus or take a subpopulation of mesenchymal cells that we can grow in a dish and transduce with CCL19, so they're now overexpressors of that molecule. If you then place them into the thymus by intrathymic injection in the animal model, this would require a ultrasound-guided administration in a human because of its close proximity to vital organs. But when this is done, in the animal, it's done blindly, but it results in an improvement in the production of T cells. The purple lines represent what happens when you place these cells in the thymus. This can be seen in either the setting of transplant or in the setting of the atrophy of age. And what you see is an increase in the number of helper cells as well as the cytotoxic T lymphocytes. This is accompanied by an improvement in a response to new antigens, vaccines, with specific T cells responding on the left, and their ability to functionally generate what we think of as an activated state on the right. So in both these settings, we have an ability to enhance the production of T cells that can potentially offset these challenges that we have, particularly in the older population. We think that we could demonstrate a biologic proof of principle in older people who have failed to respond to things like a flu vaccine. In that group, we know that that's well-documented, frequent problem. And if we were to ask those people to volunteer, we think we could test whether or not these strategies would allow for improved production of response to that type of a vaccine. In addition, in the setting of an acute allogeneic bone marrow transplant, we think that would be, as a relatively rapid clinical set of parameters that can be measured, that we think would be the process for achieving registration. Ultimately, this would obviously be something where, if highly tolerable and could be readily administered with high efficacy, that the elderly population with immunosenescence, either because of poor response to vaccines or to viruses or cancer control, that it might be useful in those contexts. We are, in fact, testing now whether or not it can improve the response to, say, immunotherapy, in particular checkpoint inhibitors, where we know many cancer patients cannot respond. We're hoping that by expanding the repertoire, we may be able to offset that. And so we want to compare with our competitive landscape. Many different things have been tried. Most are either impractical or ineffective. And what's currently active are really only two approaches. One is recombinant protein that's being used in the setting of graft versus host disease currently in stem cell transplant. And another is to culture cells outside the body, which requires an extensive culture. And it does need to be done on a donor-specific basis. These are bespoke for every individual. The advantages we think with our approach are that the Cryogel can be an off-the-shelf product. It does not require any matching with the individual. It does not have to involve the individual because it is completely acellular. It's simply administered subcutaneously, and it provides a durable source of production of these cells that then go to the thymus and can be useful. The other is the CCL19 cells, which we think can be, again, allogeneic. They can be provided as from a simple cell culture, but then have master banks that'll be available. And we find that these cells, when injected, are durable for at least 6 weeks, an interval where we could get T cell production. So our next steps are to go to the non-human primate, where we are currently funded by the NIH to do such validations. We are scaling up manufacturing at the Wyss Institute with internal funding from the Wyss. We have only tested each of these individually and now seek to do combination studies. And we are funded through a cancer NCI moonshot approach, a moonshot mechanism to test whether or not we can improve the cancer immunotherapy outcome. And with that, I'll close and thank you for your attention. I'll be happy to take any questions.